Welcome to the CGA-IGC podcast series, brought to you by CGA's Education Committee and made possible through the generous support of our sponsor, the King Center for Lynch Syndrome at Penn Medicine's Abramson Cancer Center. Each episode of CGA's podcast series provides an in-depth discussion related to emerging data, clinical challenges, and unique perspectives in the world of hereditary GI cancers. Before we start, we'd like to remind you that the content of this podcast is not intended to replace professional medical advice, diagnosis, or treatment, and the content reflects expert opinion at the time of recording. Keep listening to find out more about this episode's host, guest, and featured topic. And be sure to learn more about our sponsor at www.med.upenn.edu/King Center.
Hello, everyone. My name is Ying Liu. I'm a GYN medical oncologist at Memorial Sloan Kettering Cancer Center in New York City, where I serve as the lead of the Inherited GYN Cancer Program. I'll be your host today. During today's podcast, I have the distinct honor of introducing our two expert guests. First of all, we have Kim Zahowski, a certified genetic counselor and assistant program director at Boston University. She is an expert in this area, and we're so excited to have her talk today about providing care to the LGBTQIA plus community. So let's go ahead and get started. So Kim, how do you define inclusive affirming care for this community, specifically in the hereditary cancer space? And what do you think are the biggest gaps or barriers that you see today in delivering this type of care?
It's a great question. And first of all, thank you so much for having me. I'm really excited that we're having this conversation, especially right now in this current landscape. In terms of inclusive and affirming care, I think this just starts with recognizing that LGBTQIA people are experts in their own bodies and lives. For example, we want to ask things like, how do you want me to talk about your body? Or what matters to you in this conversation? Because that helps shift the power dynamic in a patient encounter. Clinically, we need to make sure that we're not making assumptions about family structures or sexuality or anatomy based on how someone presents. We need to separate sex assigned at birth and gender. We need to ask about partnerships and family compositions without assuming heterosexuality or traditional family structures. So it's also really important for providers to be informed about how gender-affirming care intersects with cancer care, which we can talk a little bit more about later, and be prepared to discuss this, normalize this, and also be prepared to discuss limitations in our collective knowledge. Now, in terms of barriers, I think there are a lot of them. They're really structural and intensifying. For LGBTQIA people, for example, they're less likely to have health insurance because health insurance is tied to a lot of things like employment and marriage. And for a lot of different reasons, mostly discrimination, LGBT people are less likely to be married or employed. Clinic spaces are often designed around women's health assumptions, for example. So when a clinic's signage exclusively is pink and says women's health, a transmasculine patient, for example, who actually may reasonably need breast cancer screening, is quite literally unintelligible in that space. But what I also really want to highlight right now that's really urgent, especially in the United States, is that the legal and political landscape is really actively hostile towards LGBT people and especially transgender people. So states are criminalizing gender-affirming care. There are many proposals to restrict reproductive technologies for same-sex couples. There's really intense scrutiny of any healthcare involving gender identity and sexual orientation. So when we're talking about hereditary cancer risk, we're often thinking about reproductive decisions, gender-affirming surgery, hormone therapy. All these things are being increasingly politicized and legally precarious. So a transgender patient considering risk-reducing surgery has to navigate not just the medical decision, but also the legal and social context around gender-affirming care. Someone considering IVF with a same-sex partner has to navigate states that this is being restricted. I also want to say that knowledge gaps among providers are intersecting with this political pressure. So many genetic counselors and oncologists haven't been trained on transgender health or gender identity, and now they're being pressured by their institutions or boards or legal teams to avoid these conversations altogether. So when institutions send messages like gender affirming care is quote unquote controversial, that translates into providers making assumptions that someone shouldn't have access to that care or that these conversations are optional. We've seen it happen. So I guess in this moment, inclusive care isn't just about being welcoming, it's also about being a buffer between patients and this increasingly hostile system.
And that is so important. And thank you so much for bringing, up these important points about both the individual patient and where they sit in this greater landscape. And I think it's so important for our audience to realize that we all need to be aware, we all need to be educated. So I think that's really one of the great things that we're trying to do today. So, what are the unique considerations then when it comes to genetic counseling and offering genetic testing to this population?
Yeah. And I think there's so much to think about. For different communities, there are different specific clinical considerations. I think a lot of the research has been done in genetic counseling related to trans folks, considering how hormone therapy and surgical history can really directly affect cancer risk. So, a trans masculine person on testosterone has different hormonal exposure than someone who's not on hormones. That's clinically relevant. Someone who's had top surgery, bottom surgery, or a hysterectomy needs specific cancer screening protocols. So, for example, top surgery doesn't remove as much tissue as a risk reducing mastectomy usually. So, those who've had top surgery may still need cancer screening and may not know that. In fact, there are multiple professional societies, including ACOG and NCCN, that recommend considering genetic testing before top surgery so those results can inform conversations about how much tissue is removed. If someone's had a vaginoplasty, that is the creation of a vagina, they still likely have a prostate cancer risk, which again, they may not be aware of and their providers might not be aware of. And sometimes, not always, that vagina is created from colon tissue. So if a person has a hereditary colon cancer condition or a colon polyp condition, that vagina might need to be screened with that in mind. So when we're talking to patients, we need to ask about, are you on hormone therapy? What hormones? Have you had any surgeries? What type and when? And then connect that directly to cancer risk assessments. The goal here is precision medicine. That's always the goal of genetic testing. So we need to understand how their actual tissue exposure and surgical history so that we can counsel accordingly. And we also want to be informed about how this can change across life stages. So someone might have genetic testing at 25, but come out as trans at 35, or they might be considering gender affirming surgery and want to know how it affects their cancer screening. We need to create space for those conversations. And right now, I'm aware that a lot of people are making medical decisions under duress, rushing to freeze eggs or access surgery because they're afraid that their access will be restricted. And I think that's really important context to think about. It's not that they're making rash decisions or ones that they'll regret, but they're expediting the speed at which they're making these decisions because of fear of how it will be restricted too.
That's really helpful to understand and sort of help us to kind of take a step back and say maybe we need to think about genetic testing earlier than we normally would or in a different context to help facilitate some of these decisions as part of a gender affirming journey in addition to cancer prevention. So to kind of help guide us, how do you approach conversations specifically around anatomy, gender identity, and cancer risk in a patient-centered way that's not going to be triggering and is patient friendly? And then what do we need to consider when it comes to what we are documenting in the electronic medical record?
Yeah, it's a great question. I mean, I think we can start by asking patients how they want to be talked about. How would you like me to refer to your body? For example, for many trans folks, they might prefer the term chest instead of breast. Or are there terms you want me to avoid or terms that you want me to use? And then using that language consistently with them. I think we can name cancers by their organ rather than gendering them. For example, when we're talking about prostate cancer risk, not talking about men's cancers, not assuming ovarian cancer risk is only related to women. It's also more specific to talk about the organs. And in the electronic medical record, I generally talk about cancer risk by the organ rather than saying male or female cancers. And again, this is also more specific. This is important to do with all patients. So in terms of like electronic medical record documentation, I think it gets complicated. I think we need to be a little bit strategic about what we document. For example, if we write that a patient is transgender in their medical record, that becomes visible to multiple providers, and perhaps the patient doesn't want multiple providers to know this. Perhaps this is something that they told you, but don't want their whole medical team to know. it also could theoretically be subpoenaed or misused. We're seeing that increasingly happen across the states. It's not a theoretical issue. Um, Different people are subpoenaing transgender health records for negative use. So I'm thinking about when I'm documenting, for example, I think about what's clinically necessary to document. How do I ensure that someone gets appropriate cancer risk counseling while also protecting their privacy? So, as we're thinking about genetic data, we need to think about how it's becoming increasingly accessible. And with political efforts to restrict LGBTQIA healthcare, I'm really genuinely concerned about how genetic information could be weaponized. A genetic test result tied to someone's gender or sex in an EMR could hypothetically again be misused. So, it could be used to argue that someone shouldn't transition, for example. I worry that it could affect custody or employment or safety. So I think we could really have a candid conversation with patients. Are there things about your identity or medical history that you're concerned about having widely visible in your chart? We can work with that while still ensuring you get appropriate care. Again, I think people really appreciate that transparency and appreciate that the providers are thinking about it.
That's such an important point because I feel like we in the genetics community, we are used to thinking about things like insurance and how your genetic information could affect discrimination. We talk about GINA and all of these things, but what other psychosocial factors? I know you talked about a few, but should we be aware of specifically around hereditary cancer and genetic testing in this population that are sort of unique to this population?
Yeah. And I think even more broadly than hereditary cancer testing, I think just broadly medical distrust is really deepening. LGBTQIA people, like especially those who are people of color or disabled or from other marginalized communities, have a lot of lived experience with discrimination and harm in healthcare. So we're seeing this really overtly live right now that this mistrust, sorry, is being actively justified. Healthcare institutions are withdrawing their services. States are passing extremely restrictive reproductive laws. So, I mean, in this context, minority stress is also heightened, and we know that minority stress increases behaviors like smoking and drinking, which of course affect cancer risk broadly. And minority stress is, the chronic stress that comes from navigating discrimination, legal threats, and uncertainty. It comes from coming out fatigue. It comes from worrying about employment or housing or safety. And that stress does affect people's health. We also need to think about how family dynamics are considered. Family dynamics in genetics always matter, right? But I think family dynamics in the LGBTQIA community can be, or not always, of course, but can be fraught. For example, someone might have experienced rejection from their biological family. They may have built a chosen family that's more relevant to their own support system. They might be navigating really complex feelings about disclosure to family members or whose support that they want. It's also worth noting that acceptance of same-sex marriage, for example, is decreasing in the current climate as well. So something that felt more stable maybe 5 years ago might feel precarious right now. And so we need to be thinking about this as we approach patient care in general, that patients don't owe us their trust. We really need to earn their trust individually as providers, but also in this broader healthcare system.
That's a really, really important point for all of us to remember as we're, meeting these patients, counseling them. What have you seen in clinical care? What assumptions or biases have you seen that could potentially negatively affect care in this population that we should be aware of?
Yeah. I think there are four large categories of assumptions. I think about family structure, reproductive assumptions, partnership assumptions, and gendered-based assumptions. So in terms of family structure assumptions, if we're talking about like family dynamics, we can't assume that everyone has a mom and a dad. Someone might have two dads. Someone might have a single parent. Someone might have no biological relatives. Someone might be adopted. When we think about family structures, we need to make sure that we're not missing important information and or signaling that only certain family types are valid. In terms of reproductive decision making, I think we assume a lot of people want to have children. So if we are saying most women with a BRCA variant want to know about this for having biological children, that assumes everyone wants children, that genetic inheritance matters for everyone, or even that people have access to reproductive technologies. For same-sex couples, reproductive options, again, are deeply restricted in many states. We can't make assumptions about what's available to people. I also think about how providers often default to saying or asking about someone's husband or wife. We could just say partner, for example, not assume someone's sexual orientation based on their appearance, not assume that someone has a partner, even. Often, providers are not taking same-sex partnerships as seriously in medical decision making, and we need to make sure we're being inclusive. And then again, I think the gendered component is also really important to think about. For example, if we're saying that breast cancer is a women's health issue, this is deeply exclusive of transmasculine and non-binary people. We know that transmasculine people are less likely to get breast cancer screening, again, because these spaces are not very welcoming to trans folks. We also know that providers don't always address appropriate cancer screening with people. So providers might not know what kind of cancer screening people need or might assume that it's going to be uncomfortable for someone. And we need to have open conversations about cancer risks and also make sure that we're appropriately educated because that's a gap too.
It's so nice how you lay out these biases and assumptions. And I know I've fallen into these. I know we all have, and it's so good to just, hear them, be aware of them, and do our best to address them. So along those lines, like what advice would you give providers if there's like one or two things they could just start, implementing in clinic tomorrow? What can we do to try to chip away at this and try to make the care better?
Yeah. So, I mean, there's a lot of things we could just implement tomorrow. I think we have a lot of long-term and short-term goals. A pretty easy one would be to revise intake forms. I think we can ask about gender identity separately from sex assigned at birth and also have pronouns as an optional add-in for those that it's important to include on there. I think in general, when we're talking to patients, we can ask about partnerships without assuming their gender. We can ask about hormone and surgery use and reproductive history and let the patients really tell us their story and use that information consistently. I also think we probably should be talking to our privacy officers about how to document appropriately without putting data at risk. How do we honor people's requests to keep sensitive information less visible while ensuring they're getting accurate care? I think that we should be asking people and figuring that out as our teams. The other thing I think we can do is we can really, just change our language and also take a stand at our institutions instead of gendered language like as a woman or as a man or men or woman, we can say based on, your own history or your family history. Instead of assuming reproductive plans, we can ask what matters to you. Instead of assuming partnership structure, we can ask who do you want involved in this conversation? And if you're getting pressured in your institution to deprioritize LGBT healthcare, to avoid documenting things, to restrict access to preventative services, we need to push back. This is institutional discrimination and it affects patient safety. Doctors, genetic counselors, healthcare providers all need to be advocating for LGBT people right now. Our willingness to advocate really matters.
That's so important. My final question for you, Kim, because this has been great. All right. What is your idea of ideal care for LGBTQIA populations in hereditary cancer in like the next 5, 10 years?
Ooh, great question. I think there are a lot of things I'd love to see happen. For example, I would love to see institutions actively protect LGBT patients with clear policies and legal protections. I would love to see a diverse oncology and genetic counselor workforce that reflects LGBTQIA identities. Our community within genetic counseling is pretty small. I'd love to see medical record systems that are designed from the ground up with LGBT people in mind. I would love to see cancer screening protocols that address diverse bodies and health needs, or even just to have the adequate data collected to know how gender affirming care impacts cancer risk so that we can actually give appropriate screening recommendations. I would love to see community engaged protocols where LGBTQIA people and communities really co-design healthcare pathways. I would love to see us as healthcare providers being explicitly positioned as advocates, not just neutral bystanders when institutional discrimination happens. Broadly speaking, legal protections that mean LGBT people aren't afraid to access genetic information. And most importantly, I think recognition that LGBT healthcare isn't controversial. It's just care. And when we center patient experiences and when we build systems that work for everyone and protect patients in a hostile climate, we're just delivering better medicine. In this moment, it's an act of resistance too.
Kim, I think you've given us all our mission, and thank you so much for your time today, and thank you for all that you've done and are doing. Moving to our second expert guest, we have Dr. Iris Romero, a professor of OBGYN at the University of Chicago, who specializes in hereditary cancer prevention and LGBTQ plus health. Dr. Romero, thank you so much for being here with us today. And to start off, I just kind of want to hear, what you do and how you personally define inclusive, affirming care for the LGBTQIA plus patients, especially in the hereditary cancer space.
Yeah, thank you so much. And I first would really just want to start by thanking the CGA-IGC for being so sort of forward-thinking and such a strong ally to this patient community by doing something like having a podcast that really centers the unique needs of this group. So I just give this organization a lot of credit for focusing on this topic. I guess how would I define it inclusive and affirming care for the LGBTQIA plus patient in hereditary cancer spaces? I think that was the question. I would define it honestly in the same way I would define inclusive and affirming care for any patient. So I think if we're just sort of in the middle of a busy clinic and we're kind of in our heads like, how should I best take care of this patient in front of me? If that's an LGBTQ patient, it's actually the same exact answer as it would be for any patient in front of you. And that really, to me, is involves just centering that patient's values, identities, following their lead, and then so in LGBTQ care, I think some real specifics are really just slowing down. We go so fast in our minds and in our clinics that's where we stumble a little bit. So slowing down and thinking carefully about the name that we're using, the pronouns that we're using, the assumptions we're making about family structure. And I think those are good little tidbits for just getting started in the visit.
That's great advice for all of us, just to slow down and just think about how we're approaching our patients. Absolutely. What do you think are sort of the biggest gaps or barriers you see today for delivering equitable care?
Well, I would say the biggest gap sort of globally is that this is really, for all intents and purposes, an invisible population in data. And so I am at this stage in my career getting a little tired of continuing to say that, because this has been an invisible population my whole life. I think it's time to stop saying it. It's time to start doing something about it. If we don't have data that informs the patients that we're caring for in front of us, it's really hard to do good medicine for them. And we've already contended with that in other parts of hereditary cancer genetics, where we acknowledge that fundamental data was drawn from populations that didn't represent sort of like the broad, for example, racial demographics that we care for. And we made real intentional efforts to start to improve that problem. So we can copy paste. It's really easy. We can just start making intentional efforts to produce data that is relevant to the LGBTQ patient population. And to me, that's as simple as in the data collection forms, having a non-binary gender option, to acknowledging in different family structures, the various compilations that make up families today. So that's from a scientific lens, I think the biggest gap with us today for equitable care. And then if we're going to take it way down in the weeds, there are still patients in this community who encounter providers who are either not ready to care for them or actually fundamentally disagree with caring for them. There's plenty of data in this patient population about really, really terrible experiences that some of them have with healthcare, and it compromises their well-being and their general health. So I think we need to have big work to do in data and real, like just upfront work to do to ensure that each patient, no matter what clinic in the whole country they walk into, they're treated with affirming and inclusive care.
That's super helpful. And I know, our listeners are really experts in kind of rare conditions, rare populations. So I think it's an ideal place to kind of start this kind of research and start this kind of counseling. Sort of along those lines, what advice would you give us? How do you yourself approach counseling and management for this community, specifically with regards to gynecologic cancer risk and syndromes like Lynch syndrome? How do you talk to them about this? And what advice would you give all of us?
Yeah. Yeah, I love this part of the mashup of my profession, taking my hereditary cancer genetics expertise and mashing it up with my specifically transgender care expertise, because I think they are very conducive partners to each other, and that's why I love hanging out with you guys, because uh, you just have the nimbleness of the way you think about things to take good care of them, and in my experience, the openness of heart and commitment to centering every patient, so it's easy to translate this care into for this patient population. Now, the one sort of caveat that I would ask our listeners to consider is that um, for let's just speak about transgender patients for now, because I think it's the easiest, is that we should first center their gender affirming care, um, and then second, center their um, cancer prevention, cancer screening care. And most of the time, those will not come into conflict with each other. They're usually not mutually exclusive goals, but in the rare instance where there may be, feel like there's a conflict between what the patient should do for their gender affirmation and what they should do for their hereditary predisposition, I would tell you that it's probably more important to lean towards their gender affirmation, because it is so damaging for these patients to have compromise in their gender affirming care. It starts affecting all aspects of their life and well-being. And so, but again, I would say that when I slow down and I really think about specifics of, let's just take one. I know a lot of us are experts in hereditary GI cancers. A transgender man with Lynch syndrome. One of the first questions that one might ask themselves is, what should I tell him about taking his testosterone, given his risk of ovarian cancer? And so as clinicians, we're sometimes taught or have the inclination to take the safest route. Well, I don't know what I should tell him about his testosterone, so it's probably just safest for me to tell him, I don't know, so you probably shouldn't take testosterone because maybe it increases your risk of ovarian cancer. In lots of medicine, that works. In a lot of healthcare, taking the path of least risk works. But in this example, that would actually be incredibly damaging to his overall health and well-being if he can't take his testosterone. And then if I slow down, and maybe I don't know this that day when I walk in the room, because maybe this is the first trans man with Lynch syndrome that I walked in a room with, to just slow down and say, I don't know today, but I'm going to find out for you and I will close the loop with you. And then outside of clinic, you could take the time to look up your specific question. And what you'll find is, one, because of my first comment, there's not going to be perfect data to inform this answer. But two, when you extrapolate data from cisgender populations to transgender populations, that most of the time, the gender affirming hormones are going to be fine for your patient with hereditary predisposition. I don't know if that answered the question, but that's sort of how I approach each of these patients.
That was incredibly helpful. I think we all need to remember that guidelines are great, but they're very rigid. And we have to think about the individual person. And I think there needs to be trust. And so you're sort of kind of emphasizing it's really important to evaluate the individual, what their priorities are. And even if we aren't experts in a certain area, we don't know, there's a whole community out there. You're providing us with this education. You are a resource. There are people who do know, and it's important to look for those answers. So I think that's really important. What advice do you have for us about medical terminology, maybe to avoid, or how should we approach procedures and exams like a pelvic exam that can be tough and maybe even traumatic for some of these patients?
Yeah. Thank you for this question. And I think we do it exactly like you just did, to acknowledge first and foremost that, well, actually, regardless of gender identity, that some of the things we ask patients to do could be hard for them. But just starting the conversation and saying, um, yeah, I just like to work in case examples because it kind of works better for my mind. Again, a Lynch patient who's a trans male who still has his ovaries. As we all know, there's an elevated risk of ovarian cancer. So depending on his age, I would want to know what's going on with his ovaries. So this is what my doctor brain is doing. But what my sitting in front of the patient brain and mouth and words would be so we've talked about the fact that this condition increases the risk of some cancers. And I always take this pause because it's highly variable how this patient population receives certain words, and you can't assume. And so I usually start with something along the lines of, are there certain words that you would like me to avoid that make you uncomfortable? And if they're like, yes, then I'll explore with them. And if they're like, no, I'm generally okay, then I would say, if at any point in our conversation, this is becoming problematic for you, let me know. Are you okay with the word ovaries? Yeah, that's fine. Okay, well, you have an elevated risk of ovarian cancer, so we do need to do ovarian cancer screening would be recommended for you. That's usually done with an ultrasound. The ultrasound, the best way we can get a look at your ovaries is actually by getting close up to the ovaries. I'm going to use a word now. Let me know if this word makes you uncomfortable. So kind of working through this conversation with the patient in front of you, and finding the words that make them the most comfortable with the conversation. Honestly, even your willingness to engage in the idea that our words have impact on that other person will just buy you so much goodwill from this patient. So if you accidentally say vagina, I mean, I'm a gynecologist, I probably accidentally say vagina like 10 times a day. The fact that I at least took the effort to say, let me know if you don't like this word, is really, really helpful. But just like all patients, transgender patients are very committed to their health, their cancer prevention. So I don't think you're going to very often encounter a transgender patient who's not going to want to engage in cancer screening and prevention because of their gender identity. If they encounter a provider who they feel is not safe or aggressive or antagonistic, that's a different story. But I wouldn't start from the pretense that they're not going to want to engage in this because of their gender identity. They don't want to die of cancer just like the rest of our patients.
Those are really helpful points and things to remember. Just like you were saying, oftentimes our gynecologic cancers, there is screening, but it's not great. It's not easy. And often we're talking about risk reducing surgeries for, hysterectomies for the uterus, bilateral self-angle oophorectomies for the ovaries and tubes. And not only is that a lot of complicated language, it's just how do you even approach that with this patient population, such a, big surgeries, and then also balance that with maybe the hormones that they're taking as part of maybe gender affirming treatment treatment, and how do you kind of meld the two together, talk about timing, and all of that?
Yeah. This is a fantastic question, and I would say this is where it's really important to follow the lead of your patient and understand their priorities. So I want to understand from them where on their gender affirming journey, where in that journey are they, or how in that journey are they thinking about the fact that it's a trans man, have a uterus, tubes, and ovaries? One. Two, how have they thought in their sort of life arc about being a genetic related parent? What you will find in the vast majority, especially in younger patients, is the answer to both of those questions are, one, I want my uterus, tubes, and ovaries out as soon as possible. It's part of my gender affirming journey and they cause me dysphoria. And two, mostly, but not always, I don't intend to be a genetically related parent. I have lots of roads to parenthood, and that's not a priority for me. That's not going to be the case all the time, of course, so don't assume that's the case. But if that's the case, then honestly, as part of their gender affirming care, the other physicians would have potentially, before you even meet them as a genetic counselor, have already taken out their tubes, ovaries, and uterus, or they would be on that path pretty quickly. And that's okay, because some people are worried like, oh, you take all that stuff out, Iris, then they're going to have to be on hormones the rest of their life. Yeah, that's the whole point. They want to be on testosterone the rest of their life because they're men and they want testosterone. And so we never worry in gender affirming care that we're taking out a uterus and ovaries of a 24-year-old, because that's part of their gender affirming care. They go through great amount of process to get that to that point with mental health providers, gender affirming care providers. It's not a decision made lightly. They know they'll need to be on hormones. And then to our benefit as hereditary cancer practitioners, we've now, as part of their gender affirming care, for all intents and purposes, eliminated their risk of uterine and ovarian cancer. And then you can do that similar sort of mental math with the breast cancer risk for the other genes too, for transgender men. That felt like a long answer.
No, that's great. That's great because it shows how well cancer prevention and gender affirming care can really align. And it sort of frees you up to not be so rigid with well, for cancer prevention, we only think about this time frame. You need to be a certain age. Usually I'm thinking about biological children, menopause, but actually in this situation, we could consider these surgeries earlier, even in the 20s, if that really is within the individual's goal and helps them on their journey. So I think that's an important point for all of us to hear, and a nuance that's really special for this population. So thank you so much for that. You do so much as one person, and you're so amazing. But I know that the system, I feel like sometimes is fighting against us. What can we do as far as a community, guideline committees, system-based care? What would make things better and easier for this community?
Yeah, I think we've already made a big step. I was really pleased in the last few years that we've made progress on the pedigree. So this seems like small and inconsequential, but for LGBTQ patient populations, of which, full disclosure, I am in the L, like things that seem small in the rest of the world, they are just so huge and affirming. So the fact that I can sit down and have a pedigree drawn that accurately as a that the fact that a transgender patient can sit down with the genetic counselor and have a pedigree that accurately reflects their lived life experience, and we've all committed as a community to this practice of how to draw pedigrees. It seems small, but it's hugely impactful for the patient population. And so I would say next up would be to try to get more there'll always be consensus, I think in my lifetime anyway, guidelines that are consensus about how to approach screening and prevention for transgender men and transgender women by the high penetrance genes would be an excellent win. I think we're probably kind of holding ourselves back because there isn't science and research to inform the recommendations, but we're going to be in a lifelong catch-22 if we're not going to put anything down on paper and agree to it until there's data to inform it, but there's not going to be data to inform it because we're not going to include them in the primary research. So I think in our lifetime, like this would be another great win, is just to get some consensus. So we are all kind of, one, the patients feel like we are centering their value in our community, and two, the practitioners don't feel like they have to make it up on their own, and they're not sure, like, well, this is what I would do. Is it what anyone else would do? So I think that would be a great win if we could get some sort of consensus type guidelines down. Yeah.
Agreed. And we in the genetics community, we're used to doing this for rare syndromes with very little data. So I think it's a good place to start and hopefully generate more data, more guidance. So
Yeah.
Dr. O'Mara, thank you so much for your time today. This was a great discussion. At this time, we will conclude this podcast. And once again, thank you to our experts for joining us for an episode of the 2026 CGA-IGC podcast series. Stay tuned for the next episode to come. Thank you to all of our listeners.